Hello everyone, welcome to my YouTube channel with new session. So today's session is about whooping cough or pertussis. These are the objectives, but first I will talk about what is pertussis. So pertussis is a respiratory infection caused by Bordetella pertussis. It is a gram-negative pleomorphic aerobic coccobacillus. The infection can affect individuals of all ages. The clinical presentation of pertussis varies, ranging from a relatively mild cough illness to a severe illness. Severe cases of pertussis can lead to pneumonia, seizures, encephalopathy, respiratory failure, and even death. It remains a significant health problem worldwide, with incidence increasing in several countries in recent years. Coming to the epidemiology part, pertussis is highly contagious and transmitted through aerosolized droplets. Household members, especially mothers, are often the source of transmission in infants. It doesn't exhibit specific seasonality in transmission. From 2000 to 2016, 339,420 cases were reported, with the majority in white individuals, 88.2%, and non-Hispanic persons, 81.3%. Hospitalization was required in 9.9% of cases, and the fatality rate was 0.1%. Infants had the highest incidence rate, 75.3 out of 100,000 population, and accounted for 88.8% of deaths. The resurgence of pertussis can be attributed to vaccine-driven selection, increased disease awareness, improved diagnostics, and waning immunity. Coming to the transmission part, as I said, pertussis is highly contagious and spreads rapidly through airborne droplets. The nasopharynx can harbor both commensal bacteria and pathogens, including Bordetella pertussis. Infected individuals transmit pertussis through coughing or sneezing. It is most infectious during the mucus-producing stage and the first 2 weeks after cough onset. It is more contagious than polio, smallpox, rubella, mumps, and diphtheria. One infected person can transmit Bordetella pertussis to as many as 12 to 17 susceptible individuals. In conversion, polio and smallpox can be transmitted to 5 to 7 susceptible individuals, rubella to 6 to 7, mumps to 4 to 7, and diphtheria to 6 to 7 susceptible individuals. Coming to the microbiology part, as I said, Bordetella are small gram-negative aerobic non-sporulating coccoid rods. Bordetella pertussis infection and disease involve 4 crucial steps: attachment, evasion of host defense, local damage, and systemic manifestation. Coming to the pathophysiology part, if you see in this picture, the transmission of bacteria by aerosols happen. Filamentous hemagglutinin and Fimbriya and even Pertactin, they are the major adhesions and virulence determinants for Bordetella pertussis. Then the multiplication of the bacteria and increase in the secretion of mucus will happen, then paralysis and destruction of ciliated epithelial cells, and then secretion of other toxins such as adenylate cyclase toxin and pertussis toxin, then inflammatory reaction, hyperlymphocytosis start to happen. So again, filamentous hemagglutinin and Fimbriya are major adhesions and virulence determinants for pertussis. Filaments hemagglutinin and Fimbriya are crucial for tracheal colonization, highly immunogenic, and present in certain acellular pertussis vaccine. There may be redundancy in the adhesion rule of Bordetella pertussis proteins, and Pertactin has been suggested to mediate attachment in the absence of filamentous hemagglutinin. Pertussis toxin acts as an adhesion and has specific recognition domain for human cilia. Evasion of host defense primarily occurs through adenylate cyclase toxin and pertussis toxin. Now, pertussis toxin targets the lung innate immune system by inactivating or suppressing G protein coupled signaling pathways. It will also delay the recruitment of neutrophils to the respiratory tract and target airway macrophages, promoting Bordetella pertussis infection. Now, what are the clinical symptoms? Pertussis symptoms typically appear 7 to 10 days after exposure. The disease is characterized by 3 stages. Catarrhal stage with symptoms similar to a minor upper respiratory tract infection, Paroxysmal stage, featuring sudden bursts of cough followed by a whoop on inspiration, and sometimes accompanied by post-tussive emesis. Convalescent stage, during which the frequency and severity of paroxysm decrease. Patients are most contagious during the catarrhal stage. The paroxysmal stage usually lasts 1 to 6 weeks but can extend up to 10 weeks. Nearly 80% of adults with confirmed pertussis experience a cough lasting at least 3 weeks, and 27% still have a cough after 90 days. There is no evidence of chronic infection or long-term carriage of Bordetella pertussis. Recurrent cough and vomiting can occur after pertussis even without Bordetella pertussis detected. Unrecognized pertussis is common in adolescents and adults, with cough and vomiting as common symptoms. 13 to 20% of adolescents and adults with prolonged cough are infected with Bordetella pertussis. Hospitalization rates for older children and adolescents range from 1 to 7%. Pertussis hospitalization is highest in adults over 65 years. Complications occur in about 5% of adult cases, like syncope, rib fractures, pneumonia, or otitis media. Prolonged cough may be the only sign of pertussis in immunized patients. 13 to 32% of adolescents and adults with cough lasting more than 6 days have evidence of Bordetella pertussis infection. Coming to the diagnosis, the gold standard for diagnosis is a positive culture of nasopharyngeal secretions, preferably an aspirate on selective reagent low-medium. PCR is a rapid test with excellent sensitivity for pertussis diagnosis. When there is a suspicion of pertussis outbreak, it is recommended to obtain culture confirmation for at least one suspicious case. PCR results may be accurate for up to 4 weeks. After the 4th week of cough, the amount of bacterial DNA in the nasopharynx diminishes rapidly, increasing the risk of false negative results. PCR assays protocols that target multiple sequences allow for differentiation among Bordetella species. Now, what are the treatments? Antimicrobial therapy in catarrhal stage alleviates pertussis symptoms. Administered therapy if clinical presentation suggests pertussis or high-risk patients. The treatment duration is 5 days for pertussis and post-exposure prophylaxis. Antimicrobial agents don't affect established paroxysmal cough but limit. It rarely develops resistance to macrolide antimicrobial agents. Penicillins, first and second generation cephalosporins are ineffective against Bordetella pertussis. Trimethoprim sulfamethoxazole can be considered as an alternative treatment for patients more than 2 months who cannot tolerate macrolides or have macrolide resistant strain. There are limited studies on trimethoprim sulfamethoxazole for pertussis treatment. Hospitalize young infants with pertussis in a facility capable of managing complications urgently. Life-saving interventions like exchange transfusion leukapheresis reported in infants with progressive pulmonary hypertension and high lymphocyte counts. If you can see in this table, as I said, the first line treatments are macrolides, which are azithromycin, clarithromycin, erythromycin, and alternatively trimethoprim sulfamethoxazole. And these are the doses. But pay attention to the comments. For azithromycin, preferred therapy due to ease of use and tolerability. It's preferred agent for infants younger than 1 month, and it has an adverse effects which is prolongation of QT interval, so careful monitoring of that. Clarithromycin, it has fewer adverse effects than erythromycin, but typically more than azithromycin. It has prolongation of QT interval similar to azithromycin, and it is an inhibitor of cytochrome P453A4, so use with caution with other cytochrome P3A4 medications. Erythromycin, it has gastrointestinal adverse effects which limit its use. It has a risk of hypertrophic pyloric stenosis in infants, and again the same thing, it has an cytochrome P3A4 inhibitor, so caution should be used with other medications that inhibit cytochrome P3A4. Trimethoprim sulfamethoxazole, As I said, it's effective for those with intolerance to macrolide antibiotics. Caution in pregnancy. Contraindicated in infants younger than 2 months or in mothers breastfeeding younger than 2 months. Coming to the prevention. In the United States, pertussis vaccines are available as acellular pertussis formulations combined with tetanus and diphtheria toxoids. 5 doses of pertussis-containing vaccine (DTaP) are recommended before entering school, 4 doses before 2 years of age and 1 dose before school entry. Adolescent and adult formulations known as Tdap vaccines have reduced quantities of diphtheria toxoid and pertussis antigens compared to DTaP. Universal recommendation: single dose of Tdap for individuals 11 years and older as replacement for decennial tetanus and diphtheria vaccine. No recommended booster doses of Tdap except for pregnant women. The CDC recommends post-exposure prophylaxis with antimicrobials for individuals at high risk and close contact. This is the reference. Thank you for listening. If you have any questions, please comment in the comments section. Please don't forget the like and subscription button. Share this video with family and friends and see you in the next video.